In the next 3 lectures, we'll be going through the brainstem, starting today with the medulla. And many review books mention these rule of 4s. And so I'm including them here to kind of walk you through them. I think there's something helpful about this. I put little footnotes in your handout just to kind of point out that they're not entirely accurate, but I think they provide kind of a big picture about the brainstem. So the first rule is that there are 4 cranial nerves in each section, which is really helpful because when we're talking about lesions of the medulla, pons, or midbrain, these patients will have focal cranial nerve deficits at the level of the lesion. So you need to know where the cranial nerves are. So for the midbrain, cranial nerves 3 and 4, we will see in and around the midbrain. Cranial nerves 1 and 2 are central nervous system pathways. So we really don't want to lump those in with the midbrain. Then we have cranial nerves 5 through 8 that are associated with the pons, although in this lecture we're going to talk about a very important part of the trigeminal system that loops down into the medulla. And we will see cranial nerves 9 through 12 associated with the medulla. But again, remember that we've got that one part of the trigeminal system that is in the medulla as well. Cranial nerves that divide evenly into 12 are found in the midline. So this is quite helpful. We'll see cranial nerves 3, 4, 6, and 12 as midline nuclear groups. And the others that don't, we will find more laterally. And we'll see as an exception here that the 7th nerve, although it starts out medially, we're going to follow this. It's both medial and lateral. So that would be one that's a little bit of an exception. We have 4 midline pathways or structures: the medial longitudinal fasciculus, the motor tract of the corticospinal tract, the medial lemniscus, and the motor nuclei. We just said of these cranial nerves, which are midline. Okay, just one exception here, that corticospinal tract, when we get up to the midbrain, we will find that it is lateral. But today we're going to talk about the medial medullary syndrome, and we'll see that this motor tract of the corticospinal tract is involved. And since the hypoglossal nerve and nucleus is medial in the medulla, we'll see that that's part of it, as well as the medial lemniscus. And then we will see that there are 4 sensory pathways that are lateral. The spinothalamic tract, we talked about in the spinal cord, that conveys pain and temperature. The spinocerebellar tracts that, remember, are conveying information from your arms and legs up to the cerebellum. The descending sympathetic chain, when we talk about Horner's syndrome, it's very important we associate this with the lateral medulla in particular. And then other sensory cranial nerve nuclei. So I had a student create this drawing some time ago, which I think there are some things worthwhile pointing out on this. So we'll be spending our entire lecture down here sort of talking about the continuation of the spinal cord and into the medulla. So first of all, let's just talk about a very large nucleus that in the spinal cord we called it the substantia gelatinosa, which remember is pain and temperature for the arms and legs. But notice here as we get up into the brainstem, here's where it's labeled, we now call it the spinal trigeminal nucleus. So all of this is the spinal trigeminal nucleus here in green. It really is just a continuation of the same group of neurons. They're also important for pain and temperature, but once we get into the medulla and pons, we're now talking about pain and temperature sensation for the face. When we're in the spinal cord, it's pain and temperature sensation for the arms and legs. Remember that in the spinal cord, we had all of these motor nerve roots that were going out to supply the arms and legs. And so as we get into the upper cervical cord, lower medulla, here's the spinal accessory nerve. We'll talk about this later, but this talks to the sternocleidomastoid and the trapezius muscles. So these are lower motor neurons going out to supply muscles. Okay, and we have another lower motor neuron here when we get up into the medulla, and this is the hypoglossal nucleus. So these are all fibers of the hypoglossal nerve going out to supply the tongue. We're going to spend some time today talking about two very important nuclear groups. Back here we have the dorsal motor nucleus of the vagus, and here we have the nucleus ambiguus. And both of these are clinically very important, so we'll spend some time talking about these because they are in the medulla. And we'll also talk about this solitary nucleus, and there's a tract associated with the solitary nucleus as well. All right, so a student created for me a really nice app here where you can look at the brainstem, you can rotate it three-dimensionally, you can go through cross-sections, and as we're going through this, don't get bogged down in the cross-sections. We want to always remember that there are pathways traveling north and south. The cortical spinal tract is traveling down, the spinothalamic tract, the dorsal columns are conveying sensation up. And so we want to remember that we've got these pathways going up and down. Always keep those in mind when we're looking at a cross-section. All right, so let's start here with a cross-section at the lowest level of the medulla. And this one I have labeled, so I have labeled and unlabeled. And we're going to start with the labeled, and then you should practice with the unlabeled. I put in asterisks in your handout. Anywhere there's something that you need to be able to identify on that slide, okay? And then I also put in bold anytime we have a new pathway or a new nuclei that shows up. So let's start with the pathways back here. And just remember, this just came from the spinal cord. So what we went through last time about the dorsal columns and the cortical spinal tract and all of that, well, we're going to look for those same things, right? But now we're in the medulla. So what was the dorsal columns of the spinal cord now looks a little different, okay? But remember, a pathway is dark. So this is the fasciculus gracilis, just like it was in the spinal cord, and this is the fasciculus cuneatus. Okay, so remember, we're still talking about, for the fasciculus gracilis, vibration proprioception below T6. For the fasciculus cuneatus, it's vibration and proprioception sensation above T6. Now we also have here a large pathway here, and then another one. They're kind of crisscrossing like this. And this is very important. This is the decussation or the crossing of the cortical spinal tract. So, of course, there are lots of upper motor neuron pathways. But when we say one side of the brain controls the opposite side of the body, this is always the pathway that we're going to talk about in that context. Okay, so once we are above this crossing, then any lesion of the cortical spinal tract will result in contralateral weakness of the arm and leg. Okay, once we are below this crossing, then a lesion of the cortical spinal tract, like in the spinal cord, will cause ipsilateral weakness below the level of the lesion. Okay, so just really important. This is actually what defines how do we know when we go from the spinal cord into the medulla. Well, this is at the lowest level here, this decussation of the cortical spinal tract. Now we have other pathways out here that we will talk about in a lot more detail in our lecture on the cerebellum coming up. So we have the dorsal and ventral spinocerebellar tracts. As a big picture, this is just conveying information to the cerebellum about where your arms and legs are in space. We also have the spinothalamic tract right here. So remember that this conveys pain and temperature, and that these fibers have already crossed over in the spinal cord. So if we have a lesion here in this lateral portion of the medulla, the patient is going to have a loss of pain and temperature on the opposite side of the body. Now as we move up into the medulla, I stopped putting an asterisk by these three pathways just because they get all kind of mushed together. It would be almost impossible to have an arrow point at it and have you determine which of these three pathways it is. I just want you to know from here on up, these are running laterally through the medulla, but we'll stop asking you to identify them. Now, what does this look like? This looks like the substantia gelatinosa. Okay, but now we are in the brainstem, and so it just changes names. It's called the spinal trigeminal nucleus. Same function though, it's pain and temperature sensation for the face. All right, so Again, the nuclei are going to look bright the way this is stained. And so back here we have a nucleus, and so this is the nucleus gracilis, or the gracile nucleus. So this is where those posterior columns will eventually synapse. And notice it's very low in the medulla. Okay, so the crossing of the corticospinal tract is low in the medulla, and the synapse for vibration and proprioception is also very low in the medulla. Okay, so if we had a lesion right here, let's say of the fasciculus gracilis, well, this hasn't crossed over yet, so we're still going to have ipsilateral loss of vibration, proprioception in that lake or below T6. Okay, in the next slide, we're going to see how, after these fibers have synapsed in the nucleus gracilis, and we'll see the nucleus cuneatus in the next slide, how these then cross over. Okay, but at this point they haven't crossed yet, so a lesion here would still result in ipsilateral loss of vibration proprioception. Now in this area in the spinal cord, we were talking about anterior horn cells here in the ventral horn. Well, these are anterior horn cells, so they're lower motor neurons. And in this very low level in the medulla, these are the lower motor neurons that make up the spinal accessory nerve that again supplies the sternocleidomastoid and the trapezius. Oh, and a student submitted some drawings, and if they're helpful for you, I thought they were kind of cool. It helped her to remember, looking at this crab, what some of the different pathways and nuclear structures represented on this cartoon drawing. Okay, so now you should practice labeling this yourself. And I mentioned that the nucleus cuneatus will show up much better as we get higher up, but we actually can see it here and here. So this is the nucleus cuneatus and the nucleus gracilis, again, for vibration and proprioception. Now, as we get a little higher up in the medulla, we had a motor decussation, and now we are seeing a sensory crossing, or a sensory decussation. Okay, and that is where these fibers from the nucleus gracilis and cuneatus cross over. Okay, we'll get to that. So let's follow our same order, though. We'll talk about pathways, and then we'll talk about nuclei. Right? So the fasciculus gracilis, boy, this is almost an entire nucleus here, but maybe there are little dark fibers here. So we get just a little bit of the fasciculus gracilis and the fasciculus cuneatus. Again, vibration, proprioception for below T6 and above T6, respectively. So I told you, you don't need to know about how to identify the spinothalamic tract and the spinocerebellar tracts. They're all out here in this lateral location. But again, there's no asterisk, so you don't need to be able to identify them. Now, what is important in this, because we are in just a little bit going to talk about medial medullary syndrome. So you need to know what is medial in the medulla. And so we'll start up at the top here. We have a pathway, and this is called the tectospinal tract. Okay, do you remember in the lecture on the spinal cord, when we were going over upper motor neuron pathways, that this is one of them? It descends from the quadrigeminal plate. Remember, that's the superior and inferior colliculus. And this is going down to cervical anterior horn cells to move your head and neck in response to vestibular or auditory input. You know, you can turn your head to look at something precisely, for example. That's the tectospinal tract right here. Okay, a very large midline pathway here is the corticospinal tract, otherwise known as the medullary pyramid. Okay, so remember, we're going up. So one section below this, we saw the crossing of the decussation of the corticospinal tract. Now we're above that. And so if I were to ask you, a lesion here would result in which of the following? Well, since this hasn't crossed yet, it would be weakness and upper motor neuron findings of the opposite, the contralateral arm and leg. Okay, and then right here we have a large pathway here that will get bigger, and this is the medial lemniscus. And notice I drew arrows from the nucleus gracilis and cuneatus. Okay, and so the medial lemniscus you want to just think of as a continuation of the posterior columns. It's conveying vibration and proprioception, but now it has crossed. Okay, so if you had a lesion of the medial lemniscus here, that would result in contralateral loss of vibration and proprioception. So again, the important difference between vibration and proprioception, which crosses, we're looking at it right here, the crossing occurs in the lower medulla, whereas the spinothalamic tract, which is out here somewhere, that crossed all the way down in the spinal cord. So these fibers here, and can you see how they're like these circular fibers here? These are called the internal arcuate fibers. So internal arcuate fibers are just describes the pathway that is crossing here and becoming the medial lemniscus. Okay, again, if we want to contrast the crossing fibers for the spinothalamic tract, remember crossed in the spinal cord, and there we called it the ventral white commissure. Crossing for vibration proprioception, we call the internal arcuate fibers. Okay, so again, here we have the nucleus gracilis, the nucleus cuneatus. So if the lesion were here, okay, you would get ipsilateral loss of vibration proprioception. But once we have a lesion here in the medial lemniscus, now we're going to have contralateral loss of vibration proprioception. And so this will be very important here when we talk in a little bit about the medial medullary syndrome. We still have the really large, again, looks kind of like the substantia gelatinosa, the spinal trigeminal nucleus out here. So again, pain and temperature for the face. Okay, and moving back here, we have several important nuclear groups. These will become more obvious as we move up, but one that is really important, I labeled it here, but of course there's another one here. This is the hypoglossal nucleus. Okay, so what is medial in the medulla? The hypoglossal nucleus, the tectospinal tract, the medial lemniscus, and the corticospinal tract. And so a lesion of the hypoglossal nucleus here will result in ipsilateral tongue deviation. And we'll go into that in a little bit more with the medial medullary syndrome. But I'll also just say that, remember, what is a lower motor neuron? It's just a neuron that talks directly to muscle. And so the hypoglossal nucleus here sends nerve fibers that go right out to the tongue. And so not only will you get tongue deviation, but you'll get atrophy and fasciculations because this is a lower motor neuron. So we're going to get lower motor neuron findings when we look at the tongue in these patients. Okay, I'm not going to talk about this here because it doesn't show up very well, but the dorsal motor nucleus of the vagus nerve is here. And then we have the nucleus, the solitary nucleus, and there's a tract that we'll see runs around it here as we move up. So for now, let's just talk about the solitary nucleus because this has a very important function. Okay, so here's the hypoglossal, dorsal motor nucleus of the vagus, and we've got the solitary nucleus and tract out in this location. So solitary nucleus and tract, I enlarged here and put in yellow the S. You want to think of this as a sensory nucleus. It has a sensory function from cranial nerves 7, 9, and 10. So it gets broad input from viscera in the head, throat, thoracic, abdominal cavities. And what we're going to really emphasize here is that very important, it gets stretch receptors from the lung and also from the arterial system, like the carotid sinus receptors, the receptors in the aortic arch. Okay, and this performs an important part of the baroreceptor reflex, which we're going to talk about in just a minute. It also is sensation for taste. So if we have a lesion of the solitary nucleus and tract, we're going to have dysfunction with taste. So lesion here, loss of taste. I'll explain this in just a minute here, but your heart rate goes up and there's blood pressure instability. So let's talk about the baroreceptor reflex. Okay, so first of all, here we have the solitary nucleus, or the nucleus of the solitary tract, right here. This is what we're talking about. So remember I said it gets stretch receptors from the lungs, but also from the arterial system. So here we have the carotid sinus and the aortic arch. So there are baroreceptors here. And what the baroreceptor reflex is, when your blood pressure and your heart rate goes up, that is sensed in these baroreceptors, which, via cranial nerves 9 and 10, input to the solitary nucleus. Okay? And so what this nucleus does here in the baroreceptor reflex is it tries to bring your pulse and your blood pressure back down. Okay, so here's how it does this. First, through an intermediary nucleus, it talks to these, they're like pacemaker cells here for the sympathetic system, called here the rostral ventrolateral medulla. Okay, and so when your blood pressure pulse goes up, this actually inhibits, see the inhibitory mark there? These pacemaker cells. Okay, these are sympathetics, part of your sympathetic system. They are normally activating your sympathetics. Remember, we talked about here in the spinal cord that mainly in the thoracic cord you have these preganglionic sympathetic neurons here. Okay, and so inhibiting this then actually results in less stimulation of your sympathetics. Okay, but also with regards to the heart, when we stimulate the nucleus ambiguous, this actually then, the solitary nucleus, this actually stimulates the nucleus ambiguous to go back and slow down your heart rate. Okay, the nucleus ambiguous here, these are parasympathetics. Remember, parasympathetic is rest and digest. So when we stimulate the solitary nucleus, okay, this ends up stimulating the nucleus ambiguous, which is parasympathetic, okay, and that brings your pulse and blood pressure back down. So it does it by two mechanisms. It does it by stimulating parasympathetics, which we see right here, and also by inhibiting sympathetics, which we see here. So this is how it works very well. I mean, you get stressed or triggered by something, your pulse, blood pressure goes up, there's a reflex to bring that down. In addition, when your pulse, blood pressure goes up, information goes into the solitary nucleus, this also has a feedback loop to your hypothalamus. Okay? And now notice that normally this pathway will stimulate the hypothalamus to release arginine vasopressin. Okay? But when your pulse and blood pressure is elevated, okay, this actually ends up inhibiting this area in the medulla that normally wants to stimulate the hypothalamus. So you actually get a reduced release of arginine vasopressin. Okay? And so since this normally wants to elevate your blood pressure, okay, this is another means. Now you're inhibiting release of something that normally elevates your blood pressure. So it's a kind of another mechanism for bringing your blood pressure down as part of this baroreceptor reflex. Okay? So that's why when we have lesions here of the solitary nucleus or the nucleus of the solitary tract, you'll have impaired taste, but it's also going to impair this baroreceptor reflex. And so that's why we tend to get blood pressure instability. And since normally this area via the nucleus ambiguous is slowing the heart, okay, if we have a lesion here, the heart rate tends to be faster, and that is called tachycardia. Okay, so this is all involved in a very important reflex because it has a clinical application called the Cushing's reflex. And the Cushing's reflex is seen in patients that have increased intracranial pressure. It could be a tumor in the brain, it could be an intracranial hemorrhage, any mass lesion. And the mechanism here is, some of it is poorly understood, but it appears that increased intracranial pressure has a mass effect then on the hypothalamic sympathetics. Okay? And that will cause the blood pressure to elevate, which can actually be a good thing in this situation. The brain needs to get a good flow of oxygen. If there's increased intracranial pressure, that's going to interfere with oxygenation of these areas. So the normal reflex is appropriate. We see this a lot, in fact, all the time in someone that has a large stroke. Their blood pressure immediately goes up. And that is the brain's sort of desperate attempt to oxygenate those neurons that are, getting reduced blood flow. Okay, but as your blood pressure goes up, well, that is going to activate these baroreceptors we talked about, which is going to feed back in as part of the baroreceptor reflex. So we're going to get activation of the parasympathetics, just like we talked about. And so your pulse rate will typically go down. Now, again, by probably just the mass effect causing distorted function of the hypothalamus and the brainstem, what we tend to see in the Cushing's reflex is that the pulse rate goes down, as we mentioned. The diastolic tends to go down, but the systolic remains elevated. So you get a really high systolic. Someone may have a systolic of 190 and the diastolic is 60. So that's kind of strange. And then you see that they have a really low pulse rate. And that mass effect on the brainstem also affects respiration. So we get irregular respirations. I'll show you a diagram later and explain more in detail Cheyne-Stokes respirations. For now, I'm just happy if you know patients have very irregular respirations. Okay, so when we see this triad, we're very concerned that this patient has increased intracranial pressure. So you're seeing this kind of a patient in the emergency room, get a brain scan. That's very important. Now, what are some other symptoms of increased intracranial pressure? We'll talk about this more later, but it kind of makes sense. If you've got a big mass in the brain, you're going to have a headache. Okay? Pressure in the brain gets pushed forward to the back of the eye. So when we look in the eye, we see swelling. That's called papilledema. Increased intracranial pressure also tends to cause nausea and vomiting. And again, kind of common sense. If you've got a big mass in the brain, that's going to distort your memory function. You'll be confused or encephalopathic. Okay, so a patient rolls into the emergency room with a headache. They're holding their head. They're throwing up. You look in the eye. You see papilledema. They're a little confused. And look at their vitals. High systolic, low diastolic. Their pulse is low. And you notice that they're breathing irregularly. So this is all, this is the triad of the Cushing's reflex. But in other causes of increased intracranial pressure, we're going to find these other symptoms as well. Get an urgent brain scan in that patient. All right, so the solitary nucleus and tract, remember, also gets information for taste. And so like all sensory information, except smell, it has to go through an appropriate nucleus of the thalamus, and that is the VPM. And we call this pathway for taste the solitariothalamic tract. So if we would happen to have a lesion here, you'd have a loss of taste sensation on that half of the tongue. Okay, so we talked quite a bit about the solitary nucleus and tract, and now let's talk about the nucleus ambiguous. And so here I emphasize the M. Solitary nucleus is a sensory nucleus. The nucleus ambiguous is a motor nucleus. And remember, it works closely together with the solitary nucleus and tract. So there are lower motor neurons from the nucleus ambiguous that travel with cranial nerves 9, 10, and 11. Very important for swallowing and phonation. So in a little bit, we'll talk about lateral medullary syndrome because the nucleus ambiguous is in the lateral medulla. And a major part of lateral medullary syndrome is these patients, their talking is often hoarse and slurred, and they swallow very poorly. They're at high risk for aspiration, which is when you drink or eat something and it goes down into the lungs because the swallowing mechanism is distorted. So again, really important, you know the nucleus ambiguous is in the lateral medulla. So a lesion here will get dysphagia, difficulty swallowing, and dysarthria, which is slurred speech. Dysphonia is kind of a soft, hoarse voice. And then hiccups are a classic feature of lesion of the nucleus ambiguous. And I probably should have you add here, because we just talked about the nucleus ambiguous, that there are parasympathetic fibers, remember, that are traveling to the heart as part of the baroreceptor reflex. So there is also a very important parasympathetic function of the nucleus ambiguous. Okay, so here we can see the nucleus ambiguus. Okay, most importantly, cranial nerves 9 and 10 that are associated with that. Okay, this kind of gives you a big picture of the drawings here that we have in all three of these lectures on the brainstem. Okay, so again, I would encourage you, click on these cross sections here in the medulla so that you can identify these, and then rotate this around so we get the three-dimensional structures. Now, as we move up a little higher into the medulla, some things become a bit more clear. We still have back here, mainly we're seeing the nucleus gracilis, but there are still some black fibers here. There's a little bit of the fasciculus gracilis and a little bit of the fasciculus cuneatus. Again, this is all dorsal columns that we just give a different name once we are in the medulla. We still have our medial pathways, the cortical spinal tract, right here, the medial lemniscus, the tectospinal tract. So these three pathways kind of stand up medially. And we can still see here these fibers, these internal arcuate fibers, coming from the nucleus gracilis and cuneatus. That's why the medial lemniscus gets bigger and bigger as we move up through the medulla. And what we see out here will get smaller and smaller, and as more of these fibers have just moved on into the medial lemniscus. Now let's talk a bit more about the dorsal motor nucleus of the vagus. Okay, which back here, I should have mentioned the nuclear groups. We have the hypoglossal nucleus. Same order here, the dorsal motor nucleus of the vagus. And here we see the solitary nucleus and tract. And the solitary nucleus and tract is just interesting. Remember, white on all of these sections are nuclear groups, and the tract then sort of surrounds the nucleus. So remember, this is sensory for taste, very important for the baroreceptor. And now we'll say a bit more about the dorsal motor nucleus of the vagus. All right, so nucleus ambiguus is parasympathetic to the heart. That's part of the baroreceptor. Dorsal motor nucleus of the vagus has parasympathetic fibers that supply the lung and GI tract up to the splenic flexure. So it has a very important parasympathetic supply to the GI tract. Okay, so if we have a lesion, and what would cause a lesion there? Well, you could have a stroke or something, but medications that block acetylcholine that is released by the dorsal motor nucleus of the vagus will block its function. So therefore, if you're losing stimulation to the GI tract, medications that block acetylcholine tend to cause constipation and urinary retention. And remember also that parasympathetics via the nucleus ambiguus to the heart also release acetylcholine, and so we'll tend to get an elevated heart rate in patients that take these kinds of medications. Okay, so again on this drawing, remember medially we have the hypoglossal nucleus, then the dorsal motor nucleus of the vagus, and the student that drew this, just to make one correction here, that the heart gets its parasympathetic supply from the solitary nucleus and tract out here. There could be a little bit of overlap, but the supply to the heart is mainly from the solitary nucleus. So for now, I want to emphasize the dorsal motor nucleus stimulates the GI tract, because we're going to talk about that later, how a lesion here could cause constipation if we're losing that stimulation of your GI tract. Recall also from our lecture in the first year on sympathetics and parasympathetics that the parasympathetics are located in cranial nerves 3, 7, 9, and 10. Okay, here in the brainstem. So in our lecture on the midbrain, we'll talk about parasympathetics to the pupil via the third nerve. Okay, in this lecture, we've talked about parasympathetics coming from cranial nerves 9 and 10, most importantly 10. Okay, and so if we want to label this, the supply to the heart as part of the baroreceptor reflex comes from the nucleus ambiguus. The supply below that to the GI tract is the dorsal motor nucleus of the vagus that's going to get the stomach and the GI tract. And remember, we also have parasympathetics coming from the lower sacral cord as well, okay, supplying the bladder, and parasympathetics that are below the splenic flexure. All right, so most importantly, again, my emphasis, none of this is important unless it has a clinical application. So the Cushing's reflex is very important, and that you understand the anatomy of that, because there's an important clinical application. You'll recognize a patient that has increased intracranial pressure and get a brain scan. Okay? The anatomy of the medulla is also important because we see two stroke syndromes, medial and lateral medullary syndrome. Okay, and so the three areas that are most important for medial medullary syndrome are the corticospinal tract, the medial lemniscus, and the hypoglossal nucleus. And I've consistently pointed those three out as being in the medial medulla. Now, what supplies the medial medulla? It's a branch off of the vertebral artery called the anterior spinal artery. And so this is a stroke of the medial medulla. And if you had to choose a blood vessel, you would choose the anterior spinal artery. Okay, so again, what's involved in medial medullary syndrome? The corticospinal tract, the medial lemniscus, and also the hypoglossal nucleus here. And so notice that the tectospinal tract is in here, but because this pathway is crossed and uncrossed, then there doesn't tend to be an important clinical application of that. So what would then a patient look like that has a stroke here that involves the medial medulla? So here's a nice cartoon drawing to show you. So the three areas that are involved. First, let's start with the corticospinal tract. So remember, this originates from the precentral gyrus and is traveling through the midbrain, the pons, and the medulla. And so if we have a lesion in the medial medulla, notice that's going to affect the corticospinal tract before it's crossed. And so a patient will have weakness on the opposite side of the body. This is an upper motor neuron pathway, so we'll also look for upper motor neuron findings in the opposite arm and leg, hyperreflexia, clonus, Babinski sign, and so on. Okay, the medial lemniscus is also here in the medial medulla, so maybe I'll just have you label this. These are the posterior columns. Okay, and so we saw that in the lower part of the medulla, these cross over. Maybe label this here as the internal arcuate fibers where they cross. And so a lesion here in the medial medulla will give contralateral loss of vibration and proprioception sensation. And here we have the hypoglossal nucleus right here, which will result in ipsilateral tongue deviation. So in this patient, here's left, we put the lesion on the left. So that means the patient is going to have right-sided weakness and upper motor neuron findings and right-sided loss of vibration proprioception. Notice that the face is not involved because in the next lecture we'll talk about the facial nucleus up here. So we're not going to get any facial weakness. And if we have a lesion involving the left hypoglossal nerve, when we ask the patient to stick their tongue out, the tongue is going to deviate to the left. Okay? And over time, we would expect this half of the tongue to develop some atrophy and some fasciculations. Okay? So if we see this triad, the patient has medial medullary syndrome, and the blood vessel you'd want to identify with that is the anterior spinal artery. Okay, so on an MRI scan, here we see the stroke in the medial medulla. Okay, and I saw a patient with this several years ago who had a bilateral medial medullary syndrome, which creates what's called the heart sign in the medulla. What we're looking at here are the corticospinal tracts right here and the medial lemniscus. So these patients tend to be quite disabled because you can imagine now they've got bilateral arm and leg weakness, bilateral loss of vibration proprioception, and they may not be able to move their tongue at all from involvement of the hypoglossal nucleus. We can't really see the lesion extending back here to the hypoglossal nucleus, but you know it would be located back here. Okay, so remember that here off the vertebral arteries, we have the anterior spinal artery, okay, that kind of come down as these paired blood vessels that supply the right and left medial medulla respectively. Now, as we move up a little higher into the medulla, we get to the level of cranial nerves 10 and 12. Okay, now we still have these pathways out here, the spinocerebellar pathways and the spinothalamic tract, but again, I haven't labeled these. We can still point out our midline pathways, the corticospinal tract, the medial lemniscus, and the tectospinal tract. Okay, but now we can also see some other nerve fibers. So here's the hypoglossal nucleus again. Now it's really large. And can you see these little black nerve fibers here and then here? So this is the hypoglossal nerve, extending straight from the hypoglossal nucleus. And remember that this is the only nerve that exits between the medullary pyramid and what we see right here, which is the inferior olivary nucleus. So this has to be the hypoglossal nerve right here. We can also see another nerve exiting here, and this is the vagus nerve. Okay, so remember the vagus nerve, we've talked about importantly that the dorsal motor nucleus of the vagus, here labeled over here, and the solitary nucleus and tract, here we see the solitary nucleus and tract, that both of these have a very important contribution here to the vagus nerve. Now, notice that we are now above the fasciculus gracilis and cuneatus. Okay, this is all now moved into the medial lemniscus. And so that has been replaced now by important vestibular pathways and nuclei. And there's only one that I'd like you to know. This is really complicated. There are 4 vestibular nuclei. There are a bunch of cochlear nuclei for sound. And I just think to know that in detail is above what you need to know at this point. But because it does have a very important clinical application, I am going to remind you here about the lateral vestibulospinal tract. So remember, a pathway here is dark, and so this has kind of a salt and pepper appearance. And so what we're looking at here is the lateral vestibulospinal tract as it is descending here. It's actually going through the inferior vestibular nucleus. You don't need to know that. I'm only bringing it up because this has an important clinical application. Remember that the lateral vestibular nucleus, which becomes the lateral vestibulospinal tract, is the important extensor upper motor neuron pathway. So it's overactivation of this pathway that causes that decerebrate posturing that patients will sometimes exhibit in a coma. Okay, so you need to identify that's the pathway that's involved, and the lesion that causes decerebrate posturing is above the lateral vestibular nucleus. So it's higher up. Again, it's a bad sign. The other pathway we can see here, this is sometimes called the dog ears of the medulla. I guess here it's kind of a butterfly appearance. This is the inferior cerebellar peduncle. And in our lecture on the cerebellum, we'll talk a lot about the different cerebellar peduncles. But for now, this contains mainly information that is coming from the arms and legs and is going up to the cerebellum. So those spinocerebellar tracts that we pointed out earlier, how do those get to the cerebellum? Well, they get there mainly through the inferior cerebellar peduncle. And there are so many of them, they're massive, and that's why this cerebellar peduncle is so large. We can also see a space opening up here. So this is the 4th ventricle. Remember, the 4th ventricle lies between the medulla, the pons, and the cerebellum. And we can also see choroid plexus, because choroid plexus that produces cerebrospinal fluid is found in all 3 ventricles, lateral, 3rd, and in this case, the 4th ventricle. Now, as we get higher up here into the medulla, the spinal trigeminal nucleus gets a little smaller. Okay, but again, remember this is still paying a temperature for the face. The inferior olivary nucleus is just massive, really large here. It's amazing how little I think we really understand about the function of the inferior olivary nucleus. But as a big picture, I would just think of this as a displaced nucleus of the cerebellum. It has a very important cerebellar function. I said you don't need to know the individual vestibular nuclei out here, but I think what is important is that these vestibular nuclei, they're getting information from your inner ears about when your head is moving around. And so if we have a lesion back here, vertigo then is going to be a very common symptom of that, which we will see in lateral medullary syndrome. And also the vestibular nuclei are important for coordinating your eyes. So a lesion here will not only give the patient room spinning, but you as the examiner, how do you objectify that? When you look in their eyes, you will see nystagmus, that rotatory eye movement. Okay? And now let's talk about lateral medullary syndrome, which is always a top 5 question, I think, on every board exam you'll take through medical school. So spend some time, get this down. It's such a high yield question. I'll just mention that for the third year clerkship for neurology, I created a custom exam for medical students, and there are over 4,000 questions in the National Board database for the neurology clerkship. And lateral medullary syndrome showed up again and again and again and again. So if you don't get this down, you'll miss many questions on many board exams in the coming years. So it's worth your time to really get this, right? So the blood vessels that supplies the lateral medulla is the pica, okay? But just like with the medial medullary syndrome, the pica also comes off of the vertebral artery. And so in lateral medullary syndrome, the blood vessel that is occluded statistically is more likely to be the vertebral artery. And we'll talk about this more in our lecture on stroke, but this is one stroke syndrome that we often see related to trauma. My first month as a neurology resident, a patient was in a hang gliding accident, and he dissected his vertebral artery and then from the trauma, and then had a stroke in the distribution of the pica. Okay, so the reason this syndrome, I think they like to ask a lot, is it really tests your anatomy of the lateral medulla. There's so much in the lateral medulla. So let's go through this. First of all, we have the vestibular nuclei that are in the lateral medulla. Okay, so I just pointed out the vestibular nuclei are right here. Okay, and so a lesion there is going to result in vertigo and nystagmus. And that often is the most dramatic presenting symptom of lateral medullary syndrome. And if you're an ER physician, vertigo is really common. And way more than 9 times out of 10, it's some inner ear problem. And so this is one you don't want to miss, though. When someone comes in with vertigo, you need to know, well, do they have these other features? If they do, they've had a stroke, and we need to do a whole different workup and treatment for this. Now, also, the descending sympathetics are in the lateral medulla. Okay, they're somewhere in here. I didn't label them. They're really small. Okay, but the descending sympathetics are here, and so that will give a patient ipsilateral Horner's syndrome. So when someone comes into the emergency room with vertigo, look in the eye. And do you see pupillary asymmetry? Do you see a smaller pupil and ptosis that would suggest a Horner's syndrome? The nucleus ambiguus is also in the lateral medulla. And notice I didn't label that because it's somewhere in this area in the lateral medulla. It's ambiguous, right? So you just need to know that it's there. I would never point to an arrow and ask you, what is this? Because, well, it's somewhere in there. All right, so what is the nucleus ambiguus important for? Talking and swallowing. Okay, so these of all stroke patients are some of the highest risk for aspirating. Okay, so if we think someone has lateral medullary syndrome, do not allow them to eat or drink, okay, because they could get a pneumonia from that. Their voice becomes soft and hoarse. That's called a dysphonia. And hiccups are a classic, this is kind of a buzzword here. If you've got a complex neurology vignette and the patient has hiccups, they probably have lateral medullary syndrome. Okay, and since crenulars 9 and 10 are important for the gag reflex, we want to ask the patient open their mouth and say, ah, check a gag reflex, and they're going to have a decreased ipsilateral gag. These patients also have ipsilateral ataxia. Why is that? Well, here's the inferior cerebellar peduncle. Okay, and so a lesion, and you'll understand this better when we have our lecture on the cerebellum, but any lesion of one half of the cerebellum or the connecting peduncle here results in ipsilateral ataxia. So it's very important we do finger to nose testing in these patients. They also have ipsilateral facial numbness. Okay, why is that? Well, here is the spinal trigeminal nucleus. Here, remember that's pain and temperature of the face. So here in the lateral medulla, a stroke here will result in some loss of facial sensation on that side. Okay, but they're going to have contralateral arm and leg loss of pain and temperature, and that is from the spinothalamic tract. And so this is all in the lateral medulla, but it's really hard to label. The spinothalamic tract is about out in this location here. Okay, so they're going to have contralateral loss of pain and temperature in the arm and leg. And so I have seen, there were board questions that just gave you a patient with one half of the face was numb and had loss of pain and temperature, and the opposite arm and leg was numb and had decreased pain and temperature. And that was still lateral medullary syndrome. Typically, you're going to get virtually all of these in lateral medullary syndrome. So this brings up an important point. In any brainstem syndrome, and I've given you two here in this lecture, we always look for the same theme, which is an ipsilateral cranial nerve deficit, okay, which in this case, we have the nucleus ambiguus, you have ipsilateral facial sensation, you're going to have ipsilateral vertigo and ataxia, and contralateral deficits in the extremities. In the case of lateral medullary syndrome, it's loss of pain and temperature. Okay? Remember that in medial medullary syndrome, they had an ipsilateral hypoglossal lesion and contralateral weakness and sensory loss. Okay? So same thing, an ipsilateral cranial nerve deficit, contralateral motor or sensory deficit in the arm or leg. Notice that patients with lateral medullary syndrome are not weak. Okay, and that's because the corticospinal tract is in the medial medulla. Okay, so they don't have weakness. So we can go through all of this again now with our lesion in the lateral medulla. Okay, so remember we said we have our vestibular nuclei here, so patients have vertigo and nystagmus. The nucleus ambiguus is here, so they get the dysphagia, the dysphonia, the hiccups. Here are the sympathetics, so they're going to get ipsilateral Horner syndrome. Here's the inferior cerebellar peduncle going out to the cerebellum, so they get ipsilateral ataxia. And here is the spinal trigeminal tract and nucleus, so they get ipsilateral facial decreased sensation. And here's our spinothalamic tract. Okay, so a lesion in the lateral medulla will give you contralateral loss of pain and temperature. So again, if we put now our lesion is on the right side, so the patient will have a loss of pain and temperature on the right side of the face and in the left arm and leg. Okay, and so here we can see, and this is really small, and I'll show you a video in class, but here's a patient who had a stroke here in the lateral medulla, and a little bit here in the lateral medulla, and the pica does supply the undersurface of the cerebellum. So the ipsilateral ataxia is not just from the inferior cerebellar peduncle lesion, but also from the undersurface of the cerebellum that's involved. Some of these pathways here that are like really hard to identify, just want you to know that the nucleus ambiguus is in the lateral medulla, about in that location.